Welcome to our second podcast on the respiratory system. In this podcast, we'll be examining the mechanisms of ventilation. We'll be looking at how gases and the physical properties of gases affect external and internal respiration. And we'll look at some of the situations that might arise based on problems with the respiratory system as well as pressure problems that we may encounter in certain situations. So first, we're going to talk about inhalation and exhalation as it relates to the actual physical mechanisms of moving air in and out of the lungs. Now, when we inhale, we can do so quietly as if you're doing right now at rest. And we call that quiet inhalation or quiet inspiration. And the muscles involved in this are the diaphragm. Now, the diaphragm, remember, separates the thoracic from the abdominal cavity. Now, its contacts on the lateral side of the body create a dome shape to the diaphragm when it's relaxed. That dome shape pushes up into the thoracic cavity. So when the diaphragm contracts, it's going to pull on those deeper lateral recesses in the abdominal cavity, and the diaphragm flattens and lowers. It's sort of like a trap door dropping out from underneath the thoracic cavity, which is going to increase the space of the thoracic cavity and therefore lower our pressure. Between our ribs, we have these muscles that are arranged, and they're most external of these sets of muscles, and we call them the external intercostals. Now, when these muscles contract, they try to pull the ribs closer to one another. But because the ribs are attached either directly or indirectly to the sternum on the ventral surface, as well as dorsally attached to the vertebral column, the ribs can't move closer together. But as you contract these external intercostals, it causes the rib cage and the sternum to move up and out, which increases almost in a three-dimensional space the volume of the thoracic cavity and lowers our pressure even more. Now, peristernal intercostals, these are the ones that are very near the sternum itself. These also are going to work in the same manner to raise the sternum, raise the rib cage, and increase that space. Now, in situations where we must breathe more deeply, maybe during exercise or when you go to the doctor and the doctor says, take a deep breath, we're also going to employ other muscles, the scalenus, pectoralis minor, sternocleidomastoid. These muscles are attached to the upper portions of our rib cage, pulling upwards basically against the neck, the cervical vertebrae. And this is going to help to raise the rib cage even further, more rapidly, so that we can take a deep breath and we can exhale more deeply. This is active inhalation. So here we have our muscles. We have our sternum, as you can see on the ventral surface. Here we have our peristernal intercostal muscles. Intercostal simply means between the ribs. And out here are going to be our external intercostals. Now we have some cutaways, so we're looking at portions of the diaphragm. The diaphragm's largely been cut away in this field. And so it's the diaphragm, the external intercostals, the peristernals that are going to contract during a quiet inhalation. And here we have the sternocleidomastoid, here we have the scalenus. These are attached to the upper portions of our ribs, and they're going to pull this entire unit up as well. That's during active inhalation. Now, to exhale, this is a trick question. What muscles do you have to contract when you exhale? And the answer is none. You simply relax the muscles that you contracted for inhalation, and gravity will take care of the rest. This passive process, when the muscles relax, the diaphragm rebounds and moves upward. The rib cage lowers and compresses. It creates a smaller volume, which is going to increase the pressure and force the air out of the lungs. Now, for active exhalation, we have another set of intercostal muscles. These are going to be the deepest of our set between our ribs, and these are the internal intercostals. These are going to contract and pull the ribs down, and this is going to lower the rib cage much more rapidly than simply gravity would be able to accomplish. And that will be active exhalation. Here we see our internal intercostals. These are on the inside. A lot of times in your anatomy textbooks, you'll see that the external intercostals, there'll be a window cut to remove portions of the external intercostals so you can see the internals underneath. these are almost running perpendicular to each other. I know you can't really see it in this illustration. It's just very artistic. But there's a different orientation which would also help you identify these as different muscles. So those are the processes, the mechanical processes of actually bringing air into and forcing it out of the lungs. As a result, we're going to have various physiological properties that are going to reflect this movement of air in and out and in and out of the lungs. Now, this may look like blood pressure register. This may look like heart rate. But what we're looking at is called a spirogram. And this is going to be just over time looking at the air moving into and out of the lung. As you inhale, the volume increases. As you exhale, the volume decreases. Now, this would be a series of quiet inhalation and exhalation that I'm illustrating here. And this is referred to as the tidal volume. Just the volume of air you move in and out of the lungs during a quiet respiratory cycle. Now, as you can see, in much that we'll see with other muscle, we're going to see in our heart function and our muscle function, there's always a built-in reserve. Because, yes, we're going to be functioning at rest, but when we get active, we need these reserves, these capacities, so we can bring in more air. And so what we're going to see is that above our tidal inhalation, we have an inspiratory reserve volume. So essentially, from our point where we exhale at quiet exhalation, all the way up to our very maximal, that's going to be our inspiratory capacity. Now, many of these are going to have physiological significance as far as diagnosis of disease. Just like we had an inspiratory reserve, here's our expiratory reserve. Now, the vital capacity, this is essentially going to be the amount of air that you can move in and out of the lungs. This is the total amount. So we go down here to our expiratory reserve, all the way up to our inspiratory reserve, and that's our vital capacity. Now, the reason you still see some space here, that's because we have a residual volume. You're not going to remove all the air from your lungs when you exhale. But if you take our vital capacity, add back that residual volume, then that's going to be your total lung capacity. Now, let's do this in text a little bit more refined. We've already said the tidal volume, inspiration, exhalation during a quiet cycle. We saw our inspiratory reserve, that amount of gas that's above that tidal inhalation. Expiratory reserve, it's below our tidal exhalation. Excluding residual volume. That's going to be what remains, just that used air that we're going to recycle as we go through other cycles of inhalation and exhalation. Total lung capacity, that's just all the gas that's in your lungs, top to bottom, including that residual volume. We saw in our previous slide the vital capacity. This is the total amount of gas that can be expired after a maximum inspiration. Functional residual, inspiratory capacity. This is going to be similar to vital amount of gas that can be inspired after a normal exhalation. There's our functional residual capacity, amount of gas remaining in the lungs after normal tidal expiration. The residual volume, that's after you have exhaled as much as you possibly can. This is after your quiet tidal expiration. Now, this is an important concept and one I really want you to remember, your total minute volume. When you are doing your tidal quiet inhalation exhalation, when you look at the volume of air you move per minute, that is going to result in the movement of 6 liters of gas every minute. And it really is right in the same ballpark with the amount of blood that's moved in and out of your heart every minute, which is about 5 liters. The total amount of blood in your body, 5.5 liters. So we're going to see these numbers continuing to crop up in the same general area. Now, the dead space, this is going to be that residual volume of air that remains only in the conducting zone after expiration. So this is like a subcategory of our residual volume. Now, as we've seen with many of our systems that we've covered, not everything works normally 100% of the time. So some pulmonary disorders that we may have, and you may experience these temporarily. Shortness of breath, for instance, is very common, and this is called dyspnea. You may have heard a term similar to this, apnea, and that's where you fail to ventilate, and we'll talk about that more as we get into our respiratory system. Asthma, however, is more of an acute disorder in which you can have an inflammatory reaction. A lot of times this is to exercise. This might be to some allergen, but it's going to cause a swelling of the bronchioles in your airway. You can see how open this bronchiole is in normal conditions. Well, constriction of the smooth muscle causes that luminal diameter to be narrowed. But inflammation as well could cause fluid to accumulate in those narrowed pathways, and you can see that this really does minimize the amount of passageway with which air can flow. Now, in many instances, we have rescue inhalers, and we've already talked about the albuterol inhalers. We can also have inhalers that might be terbutaline, and this is a specific beta-2 agonist. And remember, those beta-2 receptors, part of the sympathetic nervous system, will lead to smooth muscle dilation and an easier time in breathing. Emphysema is a more chronic or long-term disorder, and what happens in this disorder is the alveoli, those small little bubbles in which external respiration occurs, they are destroyed. They're replaced by connective tissue. So you simply don't have the alveoli with which to exchange gases, and this is not a reversible situation. And so with the loss of the alveoli, what's going to happen is you have certain symptoms. You're going to have shortness of breath at first when you exert yourself. As the emphysema gets worse and worse because of this destructive disease, you're going to have shortness of breath even when you're resting. This is going to lead to hyperventilation, an expanded chest when you try to breathe, because you're trying to bring in as much air as you can at any one time because you're not getting the oxygen. You're actually starving your body for oxygen. Here we see an illustration showing normal lung tissue towards the bottom, and we can see our nice little alveolar sac. But with emphysema, you can see many of those alveoli have been destroyed, at least half. And that lung tissue is going to continue to be destroyed. Now, you can stop whatever agent is causing the emphysema. You can stop and therefore conserve and protect the healthy tissue, but you will never regain the dead tissue from emphysema. Now, COPD, this is one that we hear a lot about these days. 20 years ago, you didn't hear much about this. But COPD, this is again going to be a chronic disorder where you have a narrowing of the passageways. But this is not like asthma. An albuterol inhaler is not going to help with this. Now, see, asthma, where it's caused by allergic responses or triggered by exercise, COPD is largely caused by noxious particles or noxious gases, and the most common cause of COPD is smoking. And this is going to basically bring on this very robust inflammatory response. And this inflammatory response is going to happen in the larger passageways, and this is going to be a little more like bronchitis. Asthma is more in the smaller passageways or bronchioles. These are in the larger passageways. And what's going to happen when you have all of this inflammation in these large bronchi, now you're going to be coughing, you're going to cough up sputum, and this is going to lead eventually to the destruction of lung tissue. So COPD will cause emphysema. But this is what blows my mind. Smoking is the leading cause of COPD. And by 2012, it's predicted COPD to be the third leading cause of death worldwide. So we are literally smoking ourselves to death. We're committing suicide on a long-term scale. And it's just beyond me that we as an intelligent people do that. Interstitial lung disease, this used to be called pulmonary fibrosis, because essentially what you're doing is this connective tissue, the interstitium, it's going to overgrow and replace the alveoli. So again, in this case, all the connective tissue simply overrides the tissue that is used for external respiration, leading to shortness of breath and all those other symptoms that we see with these obstructive disorders and destructive disorders like emphysema and COPD. But this is interstitial lung disease. All right, well, let's get back to looking at gases just a little bit. We've left a lot of the anatomical problems that we can have with narrowing the passageways, blocking the passageways, destroying the alveoli. But now as we look at gas exchange, remember we talked about 760 millimeters of mercury. This is 1 atmosphere of pressure. So the gases that we're working with, and these pressure differences help us inhale and exhale, and we're creating those artificial high pressure, low pressure by changing the volume of our thoracic cavity. Well, now we're going to see that pressures can also affect what kinds of mixtures we have in our gases. And Dalton's law says that when you look at the total pressure of a gas, in our case at sea level we're talking about 760 millimeters of mercury, this is going to be equal to the partial pressures of all of the components of that particular gas. You know, our air is not just pure oxygen. Our air is a mixture. And so we see, for instance, that our total pressure is going to equal the partial pressures of nitrogen, oxygen, carbon dioxide. We're going to have a few others, but these are the three principal ones we deal with. And all these partial pressures will add up to our 760 millimeters of mercury, or the 1 atmosphere. Now for air, oxygen's about 21%, nitrogen 78%. And so we see, just an approximation, our partial pressure of oxygen is about 160 millimeters of mercury. Partial pressure of nitrogen, almost 600. Now we're just going to illustrate this point. We'll come back to this. But when you take those gases and you essentially dissolve those gases in a fluid, what we're going to see, plasma, for instance, just bubbling our oxygen. In this case, our oxygen's at 100 millimeters of mercury. That's just in this gas tank, our air that we have here. When we bubble that in, we're going to see that we're going to dissolve about 0.3 mils of oxygen per 100 mils of plasma. That's going to be the oxygen content. But when we look at whole blood and actually measure how much oxygen is actually dissolved in whole blood, that number goes up to about 20 mils of oxygen per 100 mils. Now we'll get back to this dissolved gases in solutions, and we'll certainly talk about red blood cells and hemoglobin when we get to our talk of whole blood. But this is sort of how the pressure differences happen. The more pressure we have, the more we're going to be able to dissolve in the plasma. Not necessarily more in the red blood cell. That's a function of hemoglobin. But we could dissolve more in the plasma. Now, when we talk about gases in fluid and blood, one area where you have to be extremely careful is when you're diving at depth. Because each 33 feet of depth is going to increase the pressure on your body, and thus on the gases and that fluid, by 1 atmosphere. Now, when we look at our blood and we look at our body is mostly water. So water vapor is going to contribute to some of that total pressure of gases. And it's going to be about 47 millimeters of mercury. So if we add that in, we have to decrease everything else. So our oxygen, now because of our water pressure, we're going to see we're about 150 millimeters of mercury. In the alveoli, we're also going to have carbon dioxide. That's coming in from when we return the carbon dioxide from our tissues back to the lungs. And so that partial pressure of CO2 is going to decrease our oxygen even further. So really, our partial pressure of oxygen in our lungs and in our air, for all intents and purposes, is going to be about 100 millimeters of mercury. That's like we saw in that previous slide. Now, Henry's law, he's the one that states that, relative to the pressure of the air and the solubility of gases in the plasma, there's going to be a direct relationship between the partial pressure of the gases in the air and that mixture and the dissolved gases in your plasma. And so that's where we get this number, 100 millimeters of mercury in air. That's going to result in the 0.3 mils of oxygen in the fluid, or approximately 20 mils of oxygen when we're talking about whole blood. So now we've included water vapor and CO2. So here is what we're looking at with our partial pressures of gases in the air, just from the environment. Relative to the humidity, that's going to be variable for our water vapor. Not a lot of CO2 in the air we breathe. There's our O2 and nitrogen content. But when we inhale that air and we add the water vapor, we add the CO2 from our aerobic respiratory cycles and our residual volume of air, that's going to decrease the partial pressure of oxygen and nitrogen to about 100 and closer to 550 rather than our 600 for nitrogen. So this is the numbers that we're going to be dealing with, and principally 40 for CO2 and 100 for oxygen. Nitrogen's just one of those inert gases that, we really don't pay a lot of attention to. It's just like filler material for our bodies. Now, relative to the dissolved oxygen and oxygen binding to hemoglobin, we can measure that with a unit that's called a pulse oximeter, or in the hospitals, the nurses and doctors, they'll just call it the pulse ox. And what it's doing, it's using two different wavelengths of light passing through the skin and detecting that light that is absorbed and reflected, and comparing the concentrations of deoxyhemoglobin, that's hemoglobin that doesn't have any oxygen attached, and oxyhemoglobin, that's going to be hemoglobin with oxygen bound to it. And when you do this in a normal individual at 1 atmosphere of pressure, so that 100 millimeters of mercury of oxygen, typically your pulse ox, or your oxyhemoglobin saturation, is going to be at approximately 97% saturated. So you basically have oxygen bound to every hemoglobin molecule. Now, here's the question, and I know you've seen patients either on television or maybe some family members. They're in the hospital and they have the cannula and they're getting 100% oxygen. We're not talking about 100 millimeters of mercury now. We're talking about 100% oxygen. So if your blood is already saturated to 97%, and you're not likely to increase that very much more than that, so it seems like overkill that you're giving all this, why are you giving the patients 100% oxygen? You think about that some? Well, the answer has to do more with the plasma than with the hemoglobin. What's going to happen, the higher the partial pressure of oxygen, the more you can dissolve the oxygen in the plasma. And so you're going to transport more oxygen to the tissues, and it's going to be easier then to unload the oxygen to the tissues because we've got such a more steep concentration gradient of oxygen in the blood and a low concentration in the cells, so the oxygen will diffuse more readily into the tissues. So the 97% saturation, that's hemoglobin. Giving a patient oxygen, we're increasing the dissolved oxygen in the plasma. So here we're going to start looking at those partial pressures of gases in different parts of our circulatory system. So when we look at our veins, our pulmonary arteries, remember these are going to be the vessels that have the lowest oxygen content. And veins and arteries, recall, they're defined by their directional flow relative to the heart. Veins move to the heart, arteries away from the heart. But in both of these cases, we're talking about low oxygen content. Our partial pressure is down to 40. Our CO2 is now up to 46. So this is our oxygen depleted blood returning to the heart. Now, in the alveoli, we already said we've got about 100 millimeters of mercury of oxygen and 40 CO2 in the alveoli. So when our oxygen depleted and CO2 overloaded blood moves into the alveoli, we're going to undergo external respiration, and then the blood in our arteries and in our pulmonary veins, we're going to load them up to 100 millimeters of mercury with oxygen, down to 40 CO2, and that's what's going to go to our tissues to be supplied. This will recycle after we give off the oxygen to our tissues and internal respiration, pick up some CO2. This is going to result in oxygen decreasing to 40, CO2 to 46. So put in a diagrammatic form, here's our alveoli, external respiration happening. We've loaded up with oxygen, go through the heart, we go to our body, internal respiration happens, and we leave with our oxygen unloaded. We picked up some CO2, and we're going to continue to do this cycle over and over and over again. That is our oxygen utilization, and that's how we transport it, and that's how we give it to our tissues. I've told classes in the past that this is a great example of how too much of a good thing is still too much. You know, water, for instance, too much water can be toxic. Well, in this case, too much oxygen can actually be toxic. If you subject yourselves to increased pressure, and certainly that above 2.5 atmospheres of pressure, the normal oxygen content, that 21% oxygen, that 100 millimeters of mercury oxygen, that can oxidize enzymes in your body, and that can be very detrimental to your nervous system. And so that's referred to as oxygen toxicity. So what divers will often do, if they're going to be at substantial depth, 2.5 atmospheres, we're talking about, less than 90 feet of water. So some divers really subject themselves to much deeper dives than that and more intense pressures. And so they will swap out the oxygen for some other inert gas. And that way you can get away from the oxygen toxicity by lowering that oxygen content. But you still have nitrogen to deal with. And at pressures, you can basically be subjected to nitrogen narcosis. Now, nitrogen narcosis is where you actually have the nitrogen being added to various molecules, enzymes. And when this happens again to the nervous system, you experience basically what resembles alcohol intoxication. And you can have really impaired judgment. And this is not going to be a good thing if you are at extreme depth. And then all of a sudden you just decide, because your reasoning is impaired, that you're going to surface quickly. Because what you have done is you have all of this oxygen, all of this nitrogen, all these gases dissolved in your blood at pressure. And when you surface too quickly, those gases are going to come out of solution, much like opening a soda bottle and releasing all that pressure, and all the bubbles come out and you end up spewing the Dr. Pepper, because that's the worst one. It goes everywhere. And if that happens, you end up with what is called the bends, or decompression sickness. And really the only way that you're going to treat this, because now you have gas bubbles in your joints, you have gas bubbles in your bloodstream, and it is extremely excruciatingly painful. You double up. And that's why they call them the bends. You just are in the fetal position, all bent together. And the only way to alleviate this is to put those gases back under pressure, and you go into a hyperbaric chamber. And you force those gases back into solution, and then you slowly bring the pressure up. And in that case, you slowly allow the gases to come out of solution rather than bubbling out of solution so rapidly. Here we see an example of a hyperbaric chamber. A lot of athletes will use these not for pressure, but remember, they lower the oxygen content. And what does that cause? That causes your body to think you don't have enough red blood cells. You make a lot of erythropoietin, increase your hematocrit. So now when you are at sea level, for instance, you have more red blood cells and you're going to have increased stamina. And that's how that works. Now, we talked about the mechanisms of breathing, the anatomy that's involved. Well, that's regulated very tightly, and it's regulated in the brainstem, and specifically in the structure we call the medulla. And in the medulla, we have an area that is called the rhythmicity center. This is going to set the rhythm for the breathing. And you have two different kinds of neurons. The I neurons for inspiration and the E neurons for expiration. They're going to set up basically like those metronome cycles that we saw in the pacemaker of the heart. They are going to depolarize and repolarize to keep the rhythm of the breathing going. Now, a little bit higher in the brainstem, we're going to have another control center, and it's called the apneustic center. The apneustic center is going to promote the process of inhaling. It promotes inspiration. And it's going to signal the rhythmicity center, while we have another area of this pons, the higher center. It's going to be the pneumotaxic center. That center inhibits inspiration. Now notice in the medulla rhythmicity center we have the inspiration and expiration, but here the apneustic and pneumatastic, they're both functioning with inspiration. Where's expiration? Well, remember expiration, quiet expiration, that is a passive process. So when you inhibit inspiration, that in fact is promoting, by default, by that passive activity, promoting exhalation. Here we can see those areas, the medulla, the higher portion of the brainstem, the pons, the rhythmicity center in the medulla, and the apneustic and the pneumataxic center in the brainstem. Here we see just a flow chart of some of this regulatory processes. Here we have the apneustic pneumataxic center in the pons. That's going to signal our rhythmicity center. We also have information coming in from chemoreceptors, which we'll talk about. That then regulates our automatic breathing that you're doing all the time. But then we also can control our breathing when we hold our breath. That's going to allow us to do that. Now, if you have a child that's pitching a tantrum in Walmart because you haven't bought them that cabbage head doll or whatever thing that is, or the wrong kind of cereal, they're going to hold their breath. And if they're stubborn enough to hold it long enough to pass out, which is this voluntary control, when they do lose consciousness, this will take over. They will start to breathe automatically. Then you can take them home and punish them however you see fit. Now that chart we show the chemoreceptors, that's that sensory information coming in that's going to tell you about the oxygen content of the blood and whether we need to increase our respiration or decrease our respiration. Now these are called chemoreceptors, and really what they're detecting are changes in pH, and we'll understand a lot more about that when we get to our system where we talk about pH balance of the blood. But in this case, what we see is the aortic bodies and carotid bodies. These are going to be our peripheral receptors in the aorta and the carotid artery, respectively, or central chemoreceptors in the medulla. They're going to detect pH changes because the more CO2 you have in your blood, the more acidic your pH of your blood becomes. Because we see carbon dioxide is going to be converted into carbonic acid, and that is what decreases that pH level. Now, under normal conditions, remember, we've got that 40 millimeters of mercury pressure for CO2. Well, if we have an increase in CO2, which can happen from hypoventilation, you're not breathing fast enough, you're not giving off as much CO2 as it's being made, that will lead to an increase in CO2, which is called hypercapnia. Likewise, hyperventilation, breathing too quickly, you're not going to have a chance to get the CO2 from the tissues to your lungs, and so you're going to be breathing too quickly. You're going to get rid of too much CO2, and that's going to be hypocapnia. Now, in these conditions, since CO2 level affects pH, we're also going to have another one that we'll talk about. Acidosis, where your pH goes too low. Alkalosis, where your pH goes too high. So when we talk about CO2, again, this goes back to our exam questions. You must be very careful about the wording of the question. If I'm talking about ventilation, the breathing, that's going to be hypo or hyper. If I'm talking about CO2 content, that's hyper or hypocapnia. And if I'm talking about pH of the blood, we're talking about acidosis versus alkalosis. So again, on that test, pay attention to those questions. Now, here we can see our carotid body and the carotid artery. Here is where our aortic body will be in the aorta, subjected to those pressures. Blood definitely is going to be flowing through these. It's a great place to detect those changes in pH, reflecting oxygen, especially reflecting CO2 content, because they're going to be directly related to each other. Now, the central chemoreceptors, those in the medulla, those are responsible for 70 to 80% of the ventilation that occurs. However, the peripheral chemoreceptors are going to be responsible for that beat-by-beat minute adjustment. That's going to be the immediate response, the rapid response to any changes that might happen. Well, the central chemoreceptors, the reason that is more, I guess for lack of a better term, chronic regulation, is it's more long-term. It's slower response. Because the CO2 has to diffuse out of the blood into your cerebrospinal fluid. Then it's going to be detected by the cells of the central chemoreceptors, and that just takes a little bit longer. Here's the process by which we see CO2 diffusing out of the bloodstream. It's going to form carbonic acid, which completely breaks down into bicarb and the hydrogen ions that are then detected as pH changes. Now we're going to see this process, and if you go ahead and just remember this process, this is largely what we're going to be using when we transport carbon dioxide. And we'll talk about that a little bit later.